Thank you, Akshay. It's a pleasure to be here and really fun to hear these other presentations. Have been very interesting. So today we're going to talk about long-term outcomes of endovascular barrel reflex amplification. Something you may have not seen yet. Horst Sievert presented data for this same device yesterday in resistant hypertension, showing really pretty remarkable responses. So today we're going to talk about heart failure and the device, and I'll show it to you in a minute, but we've all seen in this meeting, so I won't go on it. There's an imbalance. We see parasympathetic withdrawal and sympathetic activation in heart failure, and that gets worse as time goes on. And we know that the barrel reflex provides a very powerful centralized neuromodulation to the autonomic nervous system. Carotid baroreceptors are mechanoreceptors, and they're located in the carotid sinus, and they're activated by stretch, not pressure. And they trigger signals to the brain, and sustained stretch of the carotid bulb causes a response that increases stretch and wall tension, and this is not related to static pressure alone. So let me show you the device to see how this works. So this is a nitinol implant, and it's implanted in a carotid artery. Patients are screened, and you're excluded to date if you've had significant carotid artery disease. But it doesn't actually increase. it reshapes the carotid artery into slightly more oblong radius and diameter, and that constant amplifies baroreceptor signals. So it's a constant stimulus to the carotid sinus. So the early feasibility study, these are the demographics. There were 29 patients. The 6 months results have been presented. I'll show you just a touch on that and then expand it to the 15 patients that have been followed now to 12 months. So they're 60 years old, BMI was 31, normal blood pressure, EGFR of 63, the usual comorbidities, end-terminal pro-BNP of 1200, ejection fraction 33%, New York Heart Association class 3, KCCQ was significantly affected at 42. They were on standard heart failure medications for reduced EF. And 10 of the 33 patients had heart failure hospitalizations in the preceding 6 months prior to the device. So here are the heart rate on the top and office systolic blood pressure on the bottom in the 29 patients for the first 6 months. And you see, so I think these are impressive because what we really haven't seen in autonomic devices yet is a change in heart rate blood pressure chronically. So this is the first time that we've seen that. And we see here at 6 months in these 29 patients, an actual drop in heart rate and a drop in systolic blood pressure. Now, if we take the 15 patients that have gone through 24 months, while this drop in heart rate is not statistically significant, we see the same amount of drop in heart rate. And I suspect that as we add the 29 patients, we'll get up to 29, we'll see that that was significant. The systolic blood pressure drop, though, however, is significantly dropped at 24 months. So again, I think really important that this is the first time in a chronic autonomic balancing therapy that we've seen the changes we would expect in heart rate and blood pressure. All right, so quality of life improves. We have 6 months, 12 months, 24 months. So you see that there's an initial 14-point improvement, then 18 points, then 26 points. And even though we only have 15 patients out here, that's still highly significant. 6-minute hall walk distance, again, pretty big difference at 6 months, 12 months, and at 24 months, again, with only 15 patients. This is still significant with an increase from 214 to 322 meters. And finally, New York Heart Association class. These are a little hard to read. I'm sorry. I want you to be able to see the improvement in New York Heart Association class from 3, which all the patients had when they were enrolled, to 2 that's in blue. So if we just look down here, of the 15 patients who've gone to 24 months, all 15 have improved from class 3 to class 2. And there's a gradual improvement, just as there seems to be an initial improvement in quality of life in 6-minute hall walk that gradually gets to be greater. Finally, some important confirmatory evidence is that left ventricular ejection fraction improves. At 6 months, we saw an increase that was significant from 35 to 40, and we see that maintained at 24 months where it's 41 and remains, even though we only have 15 patients here, remains significant. So this is a measurable and I think clinically significant improvement in ejection fraction. And end-terminal pro-BNP drops by about 30% initially at 6 months, and that drop is maintained over 24 months. And if we look at the heart failure hospitalizations, this is fraught with all the errors of patients have medication change when they come. But there was a much higher hospitalization rate in the 6 months prior to the device than in the 24 months after by year. So in conclusion, the Mobius HD device have had 33 total implants They're positive mechanistic indicators with reduced post-procedural heart rate and systolic blood pressure. Significant improvements also have been maintained through an extended 24-month period in quality of life, exercise capacity measured by 6-minute hall walk distance, left ventricular ejection fraction, and reduced end-terminal proBNP levels. There are reduced hospitalizations following EVBA, and the study is ongoing with additional clinical sites in Canada, Australia, and Germany, planned for the U.S., and the pivotal trial is now just about completely planned. So thank you very much.
Thanks very much. So this paper is open for discussion, and if I can just lead, just to outline for us the periprocedural anticoagulation, and then are there concerns about an implanted device and risk for late stenosis or other problems?
Yeah, so there's 6 weeks of antiplatelet where it appears that it endothelializes.
Okay.
And of course, they're screened so that they don't have carotid disease. So I think there's always concern for cerebral events, and in this population, MRIs were done in the first 6 months, and there were 3 of those. Now I'm forgetting the little acronym for when you see something on the MRI, that it's just a little like white spot on the MRI. There were 3 of those in the first 29 patients on the MRI, which went away at 12 months, were no longer present at 12 months. That is about, this is small numbers of course, but that's about the same rate you see with just carotid angiography. So, but they did disappear. But obviously, it's always a concern when you put something in the carotid artery, I think.
We have one question from Maya.
JoAnn, continuing our morning discussion of devices versus drugs, why not just to give Ivabrine?
So the question is, why don't you just give Ivabradine? And I think, well, we're hoping that this device, so Ivabradine, so that would depend on these patients. So let me start over. These patients started with a baseline heart rate of 82, so you're right, they could have been candidates for Ivabradine. And we would have an improvement in potentially hospitalizations, not an improvement in cardiac, long-term mortality. And if I'm correct, we don't have really quality of life exercise too much data in this population with Ivabradine. Maybe we do, and I don't know that. So certainly that would be one more thing here to consider. But we're hoping that with so we've been looking for a device that really has autonomic benefits, and so far we're waiting to see one that has effects on morbidity and mortality. But this is, as I said, the first time we've seen what we would have expected is a substantial reduction in heart rate. So yes, that would be a valid criticism. Why not just give them Ivabradine first? Now we might say that for all the autonomic, it would be a reasonable criticism, right, of all the autonomic studies that have been evaluated, as long as the heart rate, I mean, the current thing says if you're above, I think 70 in the guidelines, it's a 2A for 70. But I think realistically in the studies, it was a heart rate of 77, where below that you didn't see a difference, and above that you did. So, but you're right, our average heart rate starting was 82, so a valid criticism of all of these studies, I think.
Any other questions for Pam?
Yeah, great presentation, JoAnn. I was intrigued by the baseline 6-minute walk of under 220 meters, if I saw it correctly.
Right.
And the improvement was impressive. So I guess my question is more advanced stage C or run-of-the-mill stage C, where do you think there's the best efficacy and safety in this HFrEF patient population?
Yeah, you're asking me a very hard question, because I think we ask that with every single, in the whole HFrEF spectrum, where is the best place for efficacy and what would it be? If you go too sick, can you have any efficacy at all? These were class 3 patients, and the EF wasn't terrible. So I would say when you get down to an EF, I don't know, you guys know this probably better than I do, but you get down to an EF below 25% and end-terminal proBNPs that are sky high, and I'm not sure anything works in those. Yeah. So, I don't know, this is New York Heart Association class 3. The end-terminal proBNP was clearly elevated for age, but not too high. The 6-minute hall walk looked bad, but so did the quality of life. I mean, 45 is a pretty bad KCCQ, so. So I don't know that, but I think sick, but not, sick, I think.
So the functional improvements seem to be, quite impressive. I'm wondering, do you have any insights into whether the peak pressure product might be actually improved? Certainly you saw the blood pressure and heart rate.
Good point. No, yeah. I think we should test that out. I think it's going to be close to be improved, though.
Yeah, I mean, that seems to be, you have improved the reserve, and so obviously,
absolutely.
If the intention is obviously to try and change that, then that may actually be the reason.
Yeah, I mean, the thing that sort of, of course, we all think, put this thing in the crowd, what are you killing me? But it's really an impressive device for resistant hypertension. Horst presented that data yesterday. So, but I mean, what intrigues me and makes me feel positive about this is we see these changes in heart rate that you would expect if you rebalance the autonomic nervous system, really for the first time with these devices. So we'll see.
Great, thank you so much. It was a great session. Thank you everyone for joining us, and enjoy the rest of your day.
Good to see you.